All right, well, we're back for part 3 of chapter 21, where we talk a little bit more about some gastrointestinal and abdominal emergencies. We're going to start off here talking about some inflammatory conditions that originate in the GI tract. Now, there's a chapter later on where we're going to discuss a lot more in depth the inflammatory response and all the things that kind of go around that. So it's not important in this section that you understand what exactly is going on with the inflammatory response, only that there's something in the gut that has triggered this inflammatory response, and to kind of understand some of the signs and symptoms that may be associated with that so that it'll guide your treatments. Just so we're kind of on the same page, inflammation is the body's response to injury or infection. It's a common response. It's a normal response. And it helps the white blood cells reach the affected area so that it can either fight off infection or maybe even limit some of the damage that an injury or infection may be causing. When this happens, the blood vessels oftentimes will expand and become a lot more permeable in that particular area. This is why you see redness and swelling, after, a couple of days after you cut your finger or something. And it's really sensitive, tender. That's because the inflammatory response has opened everything up so it can fight some infection or something that doesn't belong. This makes it easier for their immune cells to get where they need to go in order to take care of business. In the GI system, inflammation can occur in different areas, and they can lead to a wide variety of different kinds of symptoms. If the inflammation is localized, the symptoms may stay to one particular area, or they could be very broad and they could affect, say, the entire colon or the entire small intestines. If bacteria is able to move into the bloodstream, it can cause sepsis. The body responds with a generalized inflammatory response. So bacteria enters the bloodstream, starts to cause sepsis, so the entire body begins to have an inflammatory response. And this response can actually begin to damage healthy tissues and organs. And in severe cases, it can even be life-threatening or even fatal. Many GI diseases are linked to this inflammation or this system-wide inflammatory response. On the other hand, there are some autoimmune diseases that can occur within the body when the body mistakenly attacks its own cells, thinking that they don't belong. It's still a part of the immune response, but it's a different mechanism. Basically, the white blood cells or the body's cells, the protective cells of the body, sees these cells that are supposed to be there. They're normal cells for the body, but it attacks them. The exact reason why this happens is unknown, but this attack can trigger an inflammatory response in and of itself, and that's why some of these autoimmune diseases will have, ebbs and flows to when they get better and they get worse. And the goal of medication is typically to kind of control those flows. Infections in the GI system typically happen in one of two ways. Either an organ ruptures in the GI tract and bacteria is leaked from the intestines into the abdominal cavity. Once bacteria gets into the peritoneal space, that bacteria can multiply rapidly because it's unchecked. This can lead to sepsis, which is a very serious condition that we'll talk about a little bit more in depth in a later chapter. If sepsis develops, mortality can increase dramatically from about 5% to nearly 70%. Peritoneal irritations usually show up as general abdominal pain. It's often spread out, but worse in the area of the most inflammation. A bowel rupture, the pain may focus on the upper left quadrant, or appendicitis is typically down in the lower right. A ruptured diverticulum, the pain may focus over the left lower quadrant. Now, that's not necessarily mean that these are absolutes, but these are kind of generalities that what we might expect to see, or the organ or the part of the digestive system that is being involved in this. However, the treatment's going to be essentially the same, and our way forward is going to be the same. If the pain is worse when coughing, that's something that's notable, or if there's rebound tenderness, that tenderness when we put pressure and then we release it. If there's rebound tenderness, that's noteworthy as well, because that does indicate typically something along the GI tract, because it's a hollow organ finding. Other signs and symptoms we might see is the abdomen may feel really, really hard, like a rock hard abs, only in someone you wouldn't expect to have that, or in a situation where you wouldn't expect to find that. If a patient may have a fever as well, and oftentimes they're going to want to curl up kind of in that fetal position to try to get some relief from the discomfort. Tachycardia, nausea, vomiting, loss of appetite, dehydration are not uncommon. And they're at risk for both hypovolemic and septic shock. The determining factor, the difference between the two, may be the presence or absence of a fever, but not necessarily all septic shocks have a fever. They can be quite the opposite. So there'll be some other clinical signs and symptoms that we'll have to look for if we want to differentiate between the two. Focus on supporting vital signs. These patients are typically very, very ill. They're typically critically ill. Make sure we treat for shock and expect to give multiple fluid boluses to maintain that blood pressure. If sepsis is suspected, norepinephrine may be needed to support perfusion. If possible, and some places can in the field check lactate levels. This helps gauge how well the body is being perfused. Antiemetics can help with nausea and vomiting, but keep in mind they also cause vasodilation, so we want to use them cautiously. Avoid analgesics in septic patients because they can mask important signs and symptoms that the physicians are going to need to be able to assess once we get them to the hospital. The hospital may give them analgesics, but that's going to be after they perform their assessment and they know what they need to know in order to go forward. Cholecystitis or gallstones or gall disorders. So cholecystitis and biliary tract disorders kind of get lumped into one category, and they involve inflammation of the gallbladder and surrounding bile ducts. Common conditions include an infection of the bile ducts, could be gallstones in there, and of course the gallstones could be in the common bile duct, and inflammation of the gallbladder, usually from gallstone blocking the duct, and of course gallbladder inflammation without stones, and we often find that in critically ill patients because kind of the way that thing plays out. Gallstones usually form when there's too much bile in the gallbladder and the gallbladder doesn't empty properly. Inflammation can also happen when the bile flows slowly, often due to either trauma, sepsis, maybe even sickle cell disease, or maybe the patient has been fasting for a long period of time. Risk factors for gallbladder includes being female, Caucasian, of older age. Obesity adds to the risk factor, or if you have had rapid weight gain. The classic 5 F's of cholecystitis are fair, meaning Caucasian, fat, female, fertile, and 40 or 50 years old. Now, once again, that's not an absolute. It is entirely possible for a teenager or a non-Caucasian male to have to deal with, have gallbladder problems. Not typically something we're going to have to worry about differentiating or diagnosing in the field because our treatment's going to be the same. The classic pattern for this, it usually starts 2 to 3 hours after eating a fatty meal with severe pain in the right upper quadrant. It may actually radiate all the way up into the right shoulder. They may have a positive Murphy sign. And so what you do is you ask them to exhale and place your fingers on the right upper quadrant just below the rib cage, and then ask the patient to inhale deeply. As they breathe in, the diaphragm drops and compress on the gallbladder. If the patient feels a sharp pain and stops inhaling, that's a positive Murphy sign and a sign of cholecystitis. Other symptoms can include nausea, vomiting, fever, jaundice, epigastric pain, tachycardia, and fever at night in the upper right, and fever and right upper quadrant pain, and maybe even jaundice color as well. Oftentimes these take a while to get diagnosed, and patients will go through, they'll have bouts of having a problem, and they may go months and they'll be okay, and then they'll have bouts. It may take a while for them to get to the point where they get this corrected, but surgery is going to be the correction. In the pre-hospital setting for us, we're going to try to make sure they're comfortable. Pain medications are generally okay, and maybe even some nausea medications. If need be ready to give them some IV fluids and support hydration. These can rupture, and if they do rupture, they can, of course, lead to infection and sepsis. So they may wind up turning shocky on us. Appendicitis typically happens when fecal matter or other debris blocks the entrance of the appendix, causing that pressure to build up. If untreated, this pressure can cause the appendix to rupture, leading to peritonitis, and then sepsis, and then ultimately death, especially in adults. So make sure that this is treated well. Oftentimes, once they'll feel this pain as the pressure builds up in the appendix, and when it ruptures, they'll feel pain and then relief. And then several hours later, they'll start complaining of a very diffuse pain throughout the abdominal cavity because of the peritonitis that's starting to set in. If they ignore that, it'll become septic. And if that progresses even further, it very well may end up in death. Peritonitis is nothing to fool around with. Of course, they can be a little tricky to diagnose, but as I mentioned, kind of how that pain progresses. The pain will start around the belly button, and they'll have a little nausea and vomiting, maybe a low-grade fever. And then they get to that ripe stage where the pain shifts to the lower right quadrant. And then when it ruptures, the pain may decrease. And then it kind of becomes generalized with some rebound tenderness. So it can get a little tricky, but pay attention to how the pain starts and how everything progresses. It usually takes about 48 hours for the pain to shift from the early to ripe stage. If the appendix ruptures, as I mentioned before, that junk inside that thing is just going to spread out throughout the abdominal cavity, and eventually it's going to cause widespread pain because of the peritonitis. So look for the signs of peritonitis. If they have severe right lower quadrant pain when coughing, that's the Dunphy sign. And the Rosving sign is pain on the right lower quadrant when the left lower quadrant is palpated. So look for those signs. They can kind of help narrow things down. But clearly, in your assessment, if you notice that they're septic and they're getting shocky and those kinds of things, it doesn't really matter what's causing it. They need to be treated and, transported and treated, and they need definitive care. In the pre-hospital setting, as I mentioned, watch out for sepsis. These do oftentimes lead to sepsis if they're allowed to drag on. Volume resuscitation may not be enough to stabilize the patient. So if crystalloids don't work, consider norepinephrine to support blood pressure, and administer pain relief medication and anti-nausea medication as indicated by your protocols. And you may need to call in to get those orders. Diverticulitis, basically what happens is there's a weak spot on the colon that forms a diverticula. And this diverticula is basically a little pocket or a little pouch. And these pouches can collect fecal matter. When this happens, diverticulosis is basically the condition where you actually have these pouches present. And then diverticulitis is what happens when these pockets become inflamed. So they get compacted or inflamed with fecal matter, very similar to what happens to the appendix. And they become inflamed and infected, and they could possibly even rupture. What's strongly suspected is usually it's a low fiber diet that leads to these harder stools and increases the risk of diverticulitis. Similar to when we're talking about the anal fistulas, those tears in the lining. Very similar to that. The harder stools creates more pressure in the colon, and it leads to bulges in the colon wall. As the feces moves through, some of it gets trapped, and it causes inflammation and infection, which can lead to further scarring, maybe some adhesions, and maybe even fistulas in the broader part of the colon. Signs and symptoms are going to include abdominal pain, usually in the left lower abdomen. Classic infection signs include a fever and elevated white blood cell count. Constipation and diarrhea, you could have either one. Probably not both, but you could have either one. But they probably have a pretty long history of constipation. Adhesions can form and lead to a narrowing of the colon. And of course, constipation and possible bowel obstructions may result from that. So if not treated correctly in the early stages, things can actually get worse. They can snowball and get worse and worse. The first step in management is to ensure that there is no severe infection present. So look for those signs of sepsis and those kinds of things. The patients may require fluid and norepinephrine to maintain blood pressure, just like others that kind of went down the same path. Focus on comfort through proper positioning, pain medications, and antiemetics to manage the nausea. Pancreatitis, on the other hand, is a bit different. It happens when the duct that carries the digestive enzymes, the exocrine part of the pancreas, which we'll talk more about the pancreas later, or at least the endocrine side of it. That duct that carries the digestive enzymes from the pancreas to drop into the digestive system gets blocked. And this causes the pancreas to begin to digest itself. I know it sounds pretty rough. It can come on suddenly, or it can be something that develops slowly over months. Episodes can be single, one-time deal, or they can be recurrent with periods of remission. The causes can include things like heavy alcohol use, maybe the presence of gallstones, could be reaction to some medicines, traumas, cancers, or even high triglyceride levels. All those fats being released. Signs and symptoms typically include sharp, severe pain in the epigastric area, pain that may radiate into the back, nausea, vomiting, fever, tachycardia, and hypotension. Those kind of go hand in hand. And they may even have some muscle spasms that are due to hypocalcemia, so those high calcium levels, or low calcium levels, I'm sorry. With pancreatitis, internal hemorrhage is a very, very serious concern. So we're going to look for the Cullen or Gray-Turner signs. The Cullen sign is a bluish discoloration around the umbilicus, and the Gray-Turner sign is a bluish discoloration around the flanks. That's an indication of internal bleeding, and it should be very noteworthy, especially in a patient that's complaining of abdominal pain in the absence of trauma. We know something serious has happened if there's no trauma. Something is ruptured inside. Follow general management guidelines for pancreatitis and keep an eye out for signs of severe hemorrhage. And of course, start fluid resuscitation as needed. These patients need to be reassessed frequently, especially when we're administering narcotics, because that's going to begin to further mask some of the pain. And it may be contraindicated to give some narcotics in some of our abdominal patients because of this. So how are we going to manage some of these chronic assess and manage some of these conditions? One of them that we see quite a bit is inflammatory bowel disease. It refers to chronic inflammation of all or part of the GI tract, including ulcerative colitis and Crohn's disease. This inflammation over time begins to damage the GI tract walls and increases the risk of cancer and other issues. Be careful though, and realize this, that inflammatory bowel disease is not irritable bowel syndrome. It's not the same. They have a similar name, but they're very different. IBS does not cause structural damage of the GI tract, whereas inflammatory bowel disease does. Irritable and inflammatory are the two big differences. Inflammatory is going to cause damage, irritable not so much. Ulcerative colitis is one of those inflammatory ones, and is caused by a generalized inflammation of the colon. This leads to a thinning of the intestinal wall and a weakened and dilated rectum. It makes the colon more vulnerable to infections and bleeding. The condition often peaks in two age groups, 15 to 25 and 55 to 65 is where we'll see these kind of start to rear their ugly head. It is more common in women than men, and about 1 in 6 patients report a family history of the disease, so there is some familial aspects to it. Signs and symptoms of ulcerative colitis include a gradual onset of bloody diarrhea, maybe a mucosal discharge, hematochezia, some bright red blood. Mild to severe abdominal pain kind of comes with it. They may have the feeling of a rectal fullness and some joint pain, skin lesions, and signs of infection, such as fever and elevated white counts. Treatment is going to depend on the degree of hemodynamic instability, so watch for signs of shock with these patients. Administer fluids as necessary and follow those general management guidelines and so that you provide general supportive care as needed. Crohn's disease is similar to ulcerative colitis, but it usually affects the entire digestive tract with a focus on the ileum. The presence of extra interstitial symptoms suggests an autoimmune component to the disease, and a family history and genetics contributes to the development of the condition. Repeated autoimmune attacks result in a scarred, narrowed, and stiff section of the small intestine, which can lead to bowel obstruction. Symptoms often include chronic abdominal pain, typically in the lower right quadrant, so it can be confused with appendicitis perhaps. But the bigger clues is going to be rectal bleeding, some weight loss, diarrhea, maybe even some arthritic symptoms, skin issues, and fever. Flare-ups and episodes typically range from mild to severe. We're going to focus on our general management guidelines and be prepared to provide volume resuscitation if necessary. It may be important for us to control nausea and consider some pain medications as well. Once they get to the hospital, the goal at the hospital is going to be to stop that inflammation and correct fluid imbalances and manage infections. And then they want to create an environment for the GI tract to heal itself, so they'll probably be on a little more restricted of a diet, and they may try to place them on some medications that's going to manage some of those, the reoccurrence of that. Irritable bowel syndrome. This is abdominal pain that occurs 1 day a week for at least 3 months and is linked to changes in stool consistency or frequency. The pain may be related to defecation. The exact cause is really unclear, but it's thought to be that there's an overgrowth of normal bacteria into the small bowel that leads to pain, bloating, and changes in bowel habits. IBS patients often show a hypersensitivity to bowel pain and a hyperresponsiveness of the bowel's smooth muscle. There may also be a link with some psychiatric disorders as well. Hyperresponsiveness of the bowel can lead to spasms, which may stop the fecal movement, causing constipation and bloating. That may also cause too rapid a fecal movement, leading to diarrhea. IBS typically begins in childhood and can be triggered by stress and is often associated with eating. So typically these episodes happen shortly after eating. IBS is a chronic condition, but you'll typically be called when the patient is having a severe flare-up, which happen from time to time. Signs and symptoms are typically individualized, but there are some commonalities to them that include abdominal pain or discomfort, usually diarrhea, and they may even have what's known as fatty stools. There's a lot of fat in the stools because everything's passing through so fast it's not getting digested. Constipation is possible, and they may even have a bloated feeling. Management for these patients, as many others, is primarily supportive. Assess the patient's mood and thought content. That may seem a little odd, but depression is very common with patients that have IBS. So when transferring care of them, be sure to relay any concerns that you may have or things that you may have discovered about their mental state. Okay, all right, so we are through part 3. One more part to go, and we'll see you guys back in just a little bit.